Good morning, everyone. I thank Dr. Padmamalini for giving me this opportunity, and I thank organizers. Well, in this talk, I will not be just showing what are all the new year entities we have seen and how we proved, because that is not going to be really matter for people who practice from all places like secondary care and primary care. So my talk will be in three different directions, where some entities where we have really proven the new year entities, and the second part where we were not able to prove but we lost the case, so our failures, and third part, the challenges faced by the primary care people, primary care physicians and secondary care physicians. To start with, all these infection we know. Now any disease we try to fit in. Maybe this is herpes, any case. No? And tuberculosis, we say that tuberculosis can present in any way, so we try to fit our suspicion of infection in this list somehow. This is what is happening always, but unfortunately, books mention that there are new diseases coming up, and there are reports from various countries and various centers that there are chikungunya outbreak, dengue outbreak, West Nile outbreak, rickettsial outbreak, and even the Rift Valley outbreak, which we are not often seeing or often realizing. And when we see the pictures, the books mention about this newer infection, it is often retinitis, chorioretinitis, vasculitis, which we often see but may not relate to the, or may not even suspect that this should be new. And when we see the past history also, it is almost always same. No, fever, headache, body ache, which we all go through even for influenza. So it's not really helpful when people say that this is a new entity and this is a clinical picture. So this is the first challenge. Anyway, we will see 4 or 5 entities that has been already published, so that just to increase the awareness. And Padmamalini reported a group of cases followed by several investigators reported in India, and you all might have had the cases, which is a disease of RNA virus. To tell, there are few RNA viruses which have similar clinical presentation. Retinitis and neuroretinitis like picture, with or without vasculitis, often no vitreous cells. And chikungunya, when it presented it in anterior uveitis or panuveitis, anterior uveitis was like any other herpetic uveitis with pigment dispersion. So at that point of time in 2006 to 8, chikungunya viral infection was there everywhere, from Africa to India and Southeast Asia. Believe me, millions of people were infected, and older people were even dying. So that epidemic got over. After that, the second epidemic of West Nile virus started coming. In between, we also had SARS, we had HN-F1 virus, but luckily those people did not develop any ocular inflammation. So the next virus that caused systemic infection and ocular presentation was West Nile virus, and I just give one case example, which was a very great case, unfortunate case. A newly married man had fever after 4 days of his wedding. Then he became drowsy, and he had viral encephalitis, got admitted in a systemic hospital, and became almost paralytic, and he was deaf and bilaterally blind. And this was the picture, 10th day of his fever. He came with bilateral vascular occlusion, and macula was dead. The retina was dead. And he didn't have vision in both eyes. It was so pathetic. And unfortunately, at that point of time, we didn't know anything about the disease. We didn't even know that he is the first case of an epidemic of West Nile virus. Subsequently, believe me, we had 350 and odd cases of West Nile virus with exactly similar presentation of retinitis, sometimes hemorrhagic borders, sometimes macular edema. And if anybody sees this, we will think of CME retinitis, no? Hemorrhage and retinitis. But all these patients are immunocompetent, healthy patient, comes with history of fever 15 days before ocular inflammation, and typical finding of retinitis as we saw in chikungunya. So even at this point of time, we thought it should be chikungunya, but there was minor variation. In chikungunya, joint pain followed the ocular inflammation. Whereas here, joint pain preceded dramatically. It was like septic arthritis. Patient had fever and patient was not able to even go to the bathroom. Then after a few days, they developed this. Even though it is a minor variation, we were able to differentiate because patient had a hyperpigmentation of the face and anasarca-like swelling. And believe there are 7 doctors in Arvindya Hospital had this infection. So we were able to closely follow them up. And two of the doctors had viral, we were able to allay virus from their blood. And these were the cases. If you see, it is very similar presentation, no? Retinitis and neuroretinitis picture, and retinitis inflammation was seen. Then when it heals, it leaves atrophic scar in the retina. And this was molecular diagnosis was done in a reference lab in Gwalior Defense Lab, and we published this. I am not going into the detail because that we will follow it at the end of the lecture. Then came the dengue. And there was another viral infection in 2012 in South India. You will not believe, the newspaper clippings will be 40 died in dengue in this particular district, and 50 died, something like that. It was very, the picture was very dramatic, and we were asking systemic people how they were diagnosing this dengue. It was painful because so many cases were loaded in government hospital. They didn't even have the kit to diagnose. They empirically diagnosed as dengue. And we asked the epidemiology department of government hospital, how come you can do that? Because you are giving in the news that it is dengue. Are you confirming it? No, it is impossible because we don't have fund. We do not even have the kit ready by the time the epidemic is over. So the press is compelling us. So we told it is dengue. But commercial kits were giving positive results. So, but we were not sure because it is not from a reference lab. This was the scenario of dengue, at least in Madurai and Tamil Nadu. And dengue from Dr. Chi Chun Payak in our audience. She has published a lot, and I'm just for the completion, I'm using her picture from that fever, from 2012 to 13, where we had several patients. We didn't have any ocular patient till now. No, it was not coming to us. And dengue, but we all know that dengue exists in India. So dengue maculopathy as well as dengue vasculitis were published in the papers, in the literature. And we had these cases not in this epidemic but previously. And now I am coming to the difficult part. This is a I'm a boy from Kerala, 12 years old, beautiful young child, came with the retinitis like this, with the history of loss of vision 3 days. He had a positive scotoma and lost vision. So he was very, very clear, but I didn't believe because no vitreous cells. I told him maybe some dystrophy, maybe you didn't notice this, other eye is absolutely normal, you can go home, because we tried everything, but we were not able to prove anything. So I just consoled the patient and sent home. But after that, in 2 days, he came with the other eye retinitis, which progressed like sun. On second day and third day, we lost that eye. And we did vitreous tab. Believe me, we had a collaborator from America, so we isolated DNA, we sent to America to D. Rishi lab, which found out SARS virus. So we have taken all the effort because the patient is losing the second eye also. D. Rishi lab did not have any clue. They did microarray. Probably the place where we went wrong is, this is all maybe RNA virus, but we sent the DNA. And RNA is very labile. You cannot send it across the globe. Anyway, we lost the game. But the sad part of the story is the patient developed viral encephalitis very next week and died out of subacute bacterial panencephalitis, which is a known entity published by our Biswas sir. And I had this first case 6 years back, and last 6 months I have 2 more cases of extremely similar picture. And how to prove? No, it is impossible. I cannot prove this because we do not have the primer right now, because it is a very, very rare entity. So even in tertiary care center, there are certain very high morbidity cases we cannot prove. Okay. Rickettsia, yes, it is there in the books, and people come with a dramatic picture of this, and believe me, we have several patients with this. So what we did, we collected serum, we collected plasma, we sent to a reference lab in France with so much effort, much money spent, and we sent nearly 40 cases, but none showed positive result. So we are not able to prove that we have rickettsia. There was no antibodies, there was no PCR was negative, maybe different strain, maybe we are stuck somewhere. So this is specifically to highlight, even in tertiary care, infectious disease need not be diagnosed successfully. If this is the case in a tertiary care, think of our poor colleagues in a primary health center. Surrounded by millions of patients, surrounded by hundreds of patients, we all have been posted in primary health center when we were young. And he will not even have time to see these maps and outbreaks. because patient come with history of fever and only he can give aspirin because he is seeing 300 cases a day. In this scenario, what he will do? He cannot go for any etiological diagnosis. So that is a major problem in our country. There is no setup like CDC or CDC like body who can help primary care physician, secondary care physician, leave alone the tertiary care people. So diagnosis itself is difficult and a challenge. And the confirmation of the diagnosis, even by chance, you know from the literature that there was an epidemic and you get similar case, by the time it gets published, the epidemic will be over. No, we will not be having a parallel thing. Okay, let us believe that you have parallelly, you have something, and how will you confirm? Family physician himself will not know which virus the patient is suffering from, and social and preventive medicine will tell the same result, same answer as they have told me, and scientists will say, you name the disease, I will confirm. Scientists can only do that. They cannot find out the new virus. And laboratory, which we all believe, the local laboratory may not be there in a primary care physician setup. Even if they have, they may not have the test ready. The ELISA test cannot be stored by the time you are going to have epidemic, because ELISA kit will expire in 6 months. If they say that they have the kit may be made in Germany, which the cutoff value will not be applicable to our patients at all. And if we know it may be a product of Western world and it is not tested in our population, how will we rely on those kits? So these are all the real problem and challenges faced by our colleagues in primary setup. We can have the bigger names like chikungunya, West Nile and dengue, but the investigations, are they available to our primary care is a major problem. And just 1 minute, I'll just tell how we diagnosed this West Nile. We carried all the samples all the way from Madurai to Gwalior, where the defense lab is there, where lot of funds are there. And initially the director was much willing to help us. So we had all our tested sample and we published. But unfortunately, the picture was so different. So we had to prove by RT-PCR, RT-LAMP assay, PCR sequencing and blast analysis, where the fund was available only in such a big setup. Then the director changed. The director told, we will not receive any civilian sample, we will receive only army people sample. So the next epidemic, we were not able to do anything, even though we had multiple publication, which is a credit to the defense lab. If this is the situation for tertiary care, think of a poor colleague in primary setup, and where will he get the help? And newer diseases outbreak occur often. Starting with the list, we need better lab support, where all of those who practice will get the support. Thank you for your attention.